All right, let's get started, and I think we'll give a few more people that will be joining us. I want to welcome everybody to another online presentation from Public Leadership Institute. This is one of our bi-monthly policy sessions, where today we're going to be talking about the status of the ACA and more specifically, what do states and localities can do for healthcare and expanding healthcare in the wake of everything that's happening at the national level. My name is Dave Woodward. I am the National Network Director with the Public Leadership Institute. I'm also a local county official and former state legislator, and this is a topic that when I served in the legislature, health policy was a big deal, and obviously there's a lot happening on a national level. This is not only a personal interest, but always looking for opportunities. Like, how do we take the national conversation into a state and local conversation? Is a personal interest of mine, and so I will be facilitating the conversation today when we have an incredible presenter that's going to be presenting a host of information for us. For those who are joining us for the first time, the Public Leadership Institute is a nonprofit, nonpartisan policy and leadership focus, or a center focused on raising public attention on key issues like the one that we're talking about today, particularly around equity and justice, and working with public leaders to more effectively improve the economic and social conditions for all people across this country. You can get a lot of information about our work at www.publicleadershipinstitute. publicleadershipinstitute.org, where you'll find a lot of publications, tools to help support the work that help support your individual leadership, that are all presented there. And now they're all on the screen at the same time. Our progressive agenda, our voicing our values, communication tool. We have a playbook on abortion rights, and a preparing to win, which is our newest publication, which is intended to be a tool to support public leaders as well as community-based organizations and how to effectively push a political agenda in their locality, their state, etc. And I encourage everyone, these are all free publications that you can download in PDF forms. You can go to Amazon and purchase them if you want hard copies. But these are all some of the materials that we have to offer to help support your individual leadership and advancing a progressive political and policy agenda in your local community. But before we kick on to the topic at hand that we're talking about today, we really do want this to be a value-added experience. We want to make sure that certain that all the questions that that you have in the space, because we do have a national expert that I'm very excited to introduce in just a second, that we want to make sure we bring your voice, thoughts, comments, questions into the conversation. To that end, there's a variety of ways to participate. One of them, if you have audio capabilities on your end, click on the hand icon at any time and signal to us that you have a question. And when we pause for questions, we'd love to unmute you and bring you into the conversation. I do realize that people join us from a variety of locations. Sometimes audio is not the most convenient. Typing questions in the question bar, we can take those questions that way. And my email, dwoodward@publicleadershipinstitute.org, is also right there on the screen. Feel free to email me if there's any questions that come in as a result of this presentation. I'm happy to get it to the experts to get you the answer that you need to advance your work. Without any further ado, I want to introduce our guest presenter today, someone that I've had an opportunity to meet and have. I mean, I'm a big fan of his work. Michael Miller is the policy director for Community Catalyst. He focuses on providing policy and strategy support to state-based consumer health policy and health advocacy groups all over the country. Over the course of his career, Michael has developed expertise in the areas of Medicaid, S-CHIP, Medicare, and developing state-level options to expand coverage for the uninsured, small group and non-group insurance reform, long-term care financing and delivery, managed care reform, and hospital community benefits and uncompensated care. Well, that's a mouthful. You basically have touched everything in the healthcare sector, and we're very fortunate to have him with us today. Prior to joining Community Catalyst, Michael was the Policy Director for Healthcare for All. He also worked for the City of Boston Elderly Commission as a policy analyst and the Alzheimer's Association of Eastern Massachusetts as Director of Community Partnership of the Community Partnership Project. Michael holds a degree from Brown University, a master's degree in public policy from Tufts. And he's going to tell you probably a little bit more about Community Catalyst, but we are incredibly happy to have you with us today to really talk about this conversation. I think it's probably apropos given that today is the first day of open enrollment of ACA under the Trump administration, and to talk about the status of ACA and what states and localities should do for healthcare coverage, especially increasing, expanding, promoting health coverage as the options exist today. So, Michael, thank you very much for being with us.
Dave, it's my pleasure.
All right, so I'm going to hand controls over to you.
Okay.
So you should get a prompt on your screen. There you go. I see your screen, so if you want to, yep, and you can start playing the presentation, or however is easiest for you to produce your, it's got to go through the show. So if you want to start from the beginning, and there you go.
So people see my screen now? Okay, great.
We see your screen. Perfect. So Michael, the floor is yours. I'm here to help support. I will be fielding questions when you ask for questions, and the floor is yours. Thanks for being with us.
Sure, Dave. Very happy to be here to talk with folks today about a very hot topic, or at least it was hot until indictments started to rain down, but it will be hot again. And that's really, in some ways, taking a little bit of a different slant on the topic of the ACA. We've been, talking about repeal, the Affordable Care Act, and capping the Medicaid program for really about a year now. But this is really to focus on what states and to some extent localities can do in that environment to really make the Affordable Care Act work better. Let me just say 2 words about Community Catalyst first. As Dave said, we're a national nonprofit advocacy organization with our home office is in Boston, but with offices in Washington, St. Louis, Pittsburgh, and where am I leaving out? Atlanta. We work in about 40 states. Our roots are in state and local advocacy, although we increasingly have done federal advocacy as well in recent years, but our roots are in the states and localities, and we work with state and local advocacy partners in about 40 states. So that's enough, I think, about CC. Let me just tell you a little bit about what I'm going to say today. We're really going to focus on the marketplace side of the Affordable Care Act, not the Medicaid expansion side, and really sort of dig into this whole issue of marketplace instability and, again, what states can do to make their ACA expansion marketplaces work better. And divide this up really into 3 topics. There's 4 questions, but it's really 3 topics. Sort of really, first, what are the problems in the marketplace? What do we mean when we talk about instability in the marketplace, and where does that come from? How do we get there? The second is a very short update on sort of federal efforts around stabilization that Congress is talking about. And then finally, the bulk of the time really spent on state action. And so why don't I just actually sort of get right into it. I'll pause for questions, I think maybe at each of those segment breaks. There's a question or 2 before getting into the state action part of the program. So we talk about market instability. Everyone talks about the ACA markets are unstable, and you have these sort of competing narratives about design flaws and sabotage and all kinds of things. So before we get into that, really, what are we talking about? And what I think people are mostly talking about is three problems, and they all connect to each other. So they're not really, you can't tease them apart entirely. They're different facets in some ways of a common problem. But so one of them is this question of plan competition, that there's counties that don't have a plan or might not have a plan. I mean, we have complete coverage now, but about a quarter of the enrollees only have one carrier choice in the ACA right now, according to the most recent data I've seen. And I think beyond whether there is a plan or there isn't a plan, the risk that a county will go bare and not have an insurer creates a lot of problems, because you can't really hold insurers accountable to much of a standard of service, benefit design, and so on, if you're constantly begging them to play. And so this risk of bare counties has created sort of an unfortunate dynamic in the Affordable Care Act. The second piece that people talk about, I think, or that as a contributor to this instability, is this idea that there's not enough customers in the marketplaces, and in particular, not the right ones. That is to say, not that the sick people shouldn't be there. I mean, that's in some ways the whole point of the ACA, is to get those people access to affordable coverage, but that it's not balanced out enough with enough young, healthy people to make the risk pool, to spread the cost of the sick population. And the third issue, certainly from a consumer point of view, we hear this a lot. I'm not sure it gets as much play in the media, but is really premiums and cost sharing are too high. You do hear some about it, in particular, I think, for the folks who aren't eligible for tax credits under the ACA. There's really two other groups. Those are the people over 400% of the federal poverty line who don't have employer-sponsored coverage, but there are really a couple other groups that also have an affordability problem, and that's some low-income people, people who live in high-cost areas. Even with a subsidy, they can't afford their premiums, and people who are sicker and don't qualify for that extra assistance that the ACA provides to certain people with cost sharing. So if you are above that income threshold and you don't qualify for cost sharing assistance, even if you get a premium subsidy, you might still have pretty big bills and have a hard time affording your health care. So those three problems, premiums and cost sharing too high, that's partly why some people don't show up. Some people don't show up, that makes the premiums higher. Don't have enough insurers, that means you don't have downward pressure on premiums. So all these things are related. Okay. So question really is why or how we got there, and some of those things relate back to decisions that were made in the design of the Affordable Care Act, and some are things that have happened since then. So the first is, people may remember that through a lot of the debate on the ACA, there was a lot of focus on the question of whether there would be a public plan option available to everybody. And obviously, there was no public plan in the final legislation, but the consequence of that, and two consequences of that really, are one, that there isn't a guarantee that there will be coverage everywhere. So then we have this sort of like, begging the plans to play kind of phenomenon. And the second is that even if you have at least a plan, maybe you have one, maybe you have two, but you don't have that downward pressure on premiums that a public option would have provided. And what that means then is premiums are higher than they otherwise would have been. The second is that in passing the ACA, there was a question about how much money Congress could agree to put towards premium assistance and cost-sharing assistance. And frankly, in our opinion at Community Catalyst, the law was somewhat underfunded. And that underfunding has consequences, which is that the premiums and co-pays that people have to pay as well as who's eligible for that assistance, is not as robust as it might otherwise be, as we think would be optimal. And that's why you still have, 30 million people who are uninsured, even after you've covered 20 some odd million via the ACA expansion. The third issue is this issue of plans that don't meet the criteria for sort of a reformed health insurance market. And you may remember that there was a lot of uproar about, well, if you like your plan, you get to keep it. No, you don't. And what to do about that. And in order to help sort of calm the waters, HHS made a determination to allow the so-called non-compliant plans that existed prior to the ACA to continue for a longer period of time, or at least allow states to allow them to continue for a longer period of time. Very helpful in the short run in terms of keeping people happy, but in the longer term what that did was that it left a lot of healthy people out in this. You have two markets. You have one that sick people can get into, and you have one that has mostly healthy people, and that has a lot of consequences for premiums. And in some states, I'm thinking Iowa, I'm thinking Tennessee, those non-compliant plans are actually a very big share of the market. And so places where the ACA maybe isn't working as well as you think it ought to, those non-compliant plans could very easily be at least one of the culprits. And then the last and more recent but very significant issue is sabotage. And I shouldn't say actually that it's entirely recent. Sabotage really started day one with some Republicans in Congress trying to undermine some of the provisions in the Affordable Care Act that were going to make it possible for insurers to get into this new line of business and sort of cushion some of the mistakes that they might make in how to price that. So Congress has been at the sabotage game really since 2010, and they've been joined very aggressively by the Trump administration, doing all kinds of things, putting out confusing messages, cutting consumer support for enrollment and for advertising, shortening the enrollment periods, all kinds of things that have gone on that have really undermined the smooth functioning of the market. So let me just pause there and see if there's a question or two that people want to ask about sort of what these problems are that we're talking about when we're talking about market stabilization and how we got there.
So Michael's setting up a lot of information in terms of the conditions that we are at. If there's clarifying questions, this is a really good opportunity to raise your hand if you have audio capabilities, or type questions in the question bar to get a really good understanding of kind of where, as we find ourselves in open enrollment right now, where do we stand, what's going on, the clarifying questions to help support that. I know it's fairly technical, but I think
yeah, that was a little weedy. Hopefully it'll be less so going forward. I just want to give people that sort of framework for how did we get here.
Right. So we got a question that's coming from Don. Can you share some examples of some specific non-compliant plans? So when you say non-compliant, what do we mean?
So the Affordable Care Act basically says you have to cover a certain scope of benefits. You can't vary premiums based on, age more than a certain amount, and you can't charge people more because they're sick. So non-compliant plans would be plans that could do those things subject to their state's insurance laws, but could, for example, say you know what? We're not going to cover your asthma, or we're not going to cover you at all. You go over to the ACA marketplace and find coverage. You can't be in our pool. Or we just don't cover that benefit, even though it's a required benefit by the Affordable Care Act. So those are the kinds of plans that are, quote, non-compliant.
And before the ACA, there were plans that were out there that provided very little benefit to people that didn't cover these level of benefits that were made obsolete after ACA because they were required
Right,
to.
very common. And, big things, we keep seeing this in the debate poking up its head. Well, we don't want to cover mental health. Well, we don't want to cover maternity care. So those were kind of benefits that were often excluded in the individual insurance market, or even prescription drugs, that just weren't available benefits to people.
Right. So, I know in my club, if I'm going off track, you feel free to stop me. But, I knew that there were in some cases where employers offered some, basically a plan where they actually paid, the employee actually paid a portion into them as well that provided virtually no benefit whatsoever, particularly the things that we all, publicly raise up as high in public support of the requirements that the ACA provides, that it wasn't until people were sick or needed health care that they learned, well, yes, that's not covered. Maternity is not covered. Your benefits capped at, frankly, in some cases, less than what you paid into it per year. And
right.
Yeah, and so that's, I think that's really important for people to realize. Yep.
You think about, the Affordable Care Act. People sometimes say, like, well, that premiums are expensive, and they are in some cases, for sure. But a lot of the cheap plans that, Dave was alluding to, they really didn't cover you if you got sick. It was only you give the insurance company money when you were healthy, and then you were kind of out of luck if you actually had a serious problem. And even if you could, once you got that problem, then you had a target on your back, and you had a pre-existing condition which would prevent you from getting covered someplace else. Right. So why don't I push on, because I do want to make sure we get to people. There'll be other opportunities for questions, and if people have more questions about this part of the sort of the history, the genesis of some of this, we can go back to that.
Sounds great.
Why don't I just take just a little bit of time to talk about what the federal debate has been about stabilizing the market. And I don't want to spend too much time with this, but people probably have heard that Senator Alexander and Senator Murray, who are the chair and the ranking minority member of the Health Committee, have reached an agreement in principle. They have filed legislation to provide do certain things that would help stabilize, or that ideally would help address some of these problems that I laid out. So the first thing is that people probably know the president canceled these so-called cost-sharing reduction payments to insurers. And I just want to make sure, I don't know everyone's baseline, so just want to make sure that people understand an important point here, which is when the president and I apologize if everyone's like, we know that, but when the president canceled those payments, he did not do anything that affects the individual consumer's right to have that cost-sharing assistance. What he said is, we are not going to pay the insurance companies back for providing that assistance, essentially. Now, this is pretty much, in our view, and I think a lot of legal experts' view, an untenable position for them. Eventually, the insurers will sue the federal government, and eventually the federal government will have to cough up the money, because what's being litigated in the court case you're hearing about right now is really essentially technicality about the mechanism for getting the money to the insurance companies. In no way does it implicate the individual's right to have that money, and it actually doesn't really relieve the federal government of their obligation to the insurers to pay them and make them whole. So it's just a question of, what's the process for insurers getting their money. And so the Alexander Murray bill proposes to guarantee those cost-sharing reduction payments, so-called, to plans for 2 years. It also restores funding for outreach and enrollment support that the president eliminated. And in exchange for that, it also gives states some more flexibility if they want to get a waiver for some of the from some of those ACA rules, and would create something called a copper plan. There's the metal levels, platinum to silver, and creates a new level plan, a kind of a catastrophic plan that only covers about 50% on average of the patient's healthcare costs. So it's a cheap insurance product with a lot of cost sharing, but it would still cover all the benefits, but there's a lot of copayments. So this was sort of the quid pro quo. You know, we'll prop up the, just make it easier for the insurers and more attractive for them to participate. We'll help support open enrollment, but we'll have these other things, you know, in exchange. Now, the problem is that all this is getting worked out. It's already too late for 2018. The rates are already cooked in 2018 with the assumption that those payments are not in the insurance. You know, the insurers are going to have to claim those payments. But they've already, in most states, raised their rates as an alternative to suing the government to get their money. And they will still sue to get this year's money. But for next year, they just built those costs right into the rate. They said, okay, we're not going to get paid back for these cost-sharing reductions. We'll just raise rates to make up for that. So those rates account for maybe, on average, about 2/3 of the rate increases that we're seeing in the ACA. So when we talk about sabotage and rate increases, you know, that's the direct cause. So what we see is, you know, these provisions, they're coming too late for this year, and it's really, at this point, not clear what the fate of this these provisions are. I'll just say that the President and Mr. Hatch and Mr. Brady have offered a different set of fixes that include getting rid of the individual mandate and the employer mandate. They include restricting plans, trying to keep plans from covering abortion, and some other things. So there's sort of like kind of competing proposals here. Just don't want to dwell too much on this. What I would say is that there's sort of a modest win for both sides if the Alexander Murray proposal is adopted. That on the one hand, it makes it, you know, rates will go down on average, and that will sort of undercut that, oh, the ACA is failing, look at the rate increases argument. On the other hand, it will also undercut the argument that, hey, you're sabotaging the ACA and making it work, because people say, like, no, I voted for this thing. So there's a little bit of a bipartisan protection there for both sides if they want to use it. But as I said, timing, you know, this wouldn't pass before December. It's really too late at that point to have an impact on either premiums or enrollment for 2018. It would only have an effect in 2019. So I don't know. Again, I can pause for a question or two if people have questions about what's in Alexander Murray, or why does it matter or not matter, or the politics of it, or anything like that. You know, happy to try and answer a question or two.
Sorry, Michael, I was on mute there. Again, if it's an opportunity, if anyone has any questions about the stuff that Michael just laid out, feel free to type the questions in your question bar, and I'm happy to read them, or raise your hand if you have audio capabilities, and we can ask them directly. Michael, in the context of what you were talking about, so what is the likelihood of a resolution here? I'll start there. Maybe people can jump in. It seems like, you know, you can get there are very few things that have been able to bring Democrats and Republicans together in this Congress all year. The fact that there seems to be some recognition, like, yes, here's a problem, here's a solution that we can all rally around. What's the likelihood?
So it's a little bit hard to say. What I would say is that the likelihood of actually adopting this depends, I think, a lot on having it hew pretty closely to the deal that Murray and Alexander worked out. There's just not that much to be gained by giving away a lot more on the Democratic side, not much to be gained by giving away a lot more in the negotiations. I think that, as a general proposition, the idea that, hey, there's a problem here, that parties can come together to work on that problem is welcome, very welcome, and I think that it also offers up a counter-narrative, if you will, to this sort of like, oh, we're going to repeal the ACA along partisan lines, which we must very much expect that to be something that rears its head again next year. So I think that from that point of view, it would be a good thing. And again, as long as people on the Republican side more or less are willing, if there's a critical mass that's kind of willing to say, like, yeah, these guys worked out a deal, let's go with it, I think it has a decent chance. I think that if they start to pile on more demands for what they want to see in exchange for 2 years of cost-sharing payments and really what boils down to 1 year of outreach and enrollment money, it's just not that worth it, in my opinion. Other people might have a different opinion. Part of the reason it's not worth it is because in most states, not in every state, but in most states, the markets have already adjusted to the fact that the CSR payments are gone. And by doing a temporary fix, a permanent fix is a completely different animal. And if they had done a fix before Trump pulled the trigger and canceled the payments, that's a different animal. But because Trump has already done the damage and the market has already started to adjust, then putting a temporary patch back in there so that will push premiums down next year, that's a good thing. Then they'll go back up again the year after unless you can negotiate a deal again. So it's kind of a mixed bag at this point, and just it's not that I would say on balance, it's not that it's not worth doing. I think it is worth doing, but I wouldn't want to give away the store for it for sure. So I don't know, that's a little bit of, likelihood and a little bit of, just sort of trying to game out the negotiations. I certainly wouldn't, want to see a lot of chasing after a deal for the sake of a deal, if there isn't a bigger upside to go with it.
Right, that makes sense. All right, doesn't look like we have any more questions specifically on this, so why don't we move into your next phase, which I imagine starts getting us to, like, well, what do we do?
Yeah, I do see something in I don't know if this is a question, somebody raised a question about the co-op plans that were supposed to help with the lack of public option. There were a couple provisions. The co-op plan was one, and this idea of a national plan was another. It just didn't really work that well. They weren't funded that well. There wasn't enough careful consideration given to what it would take to actually launch new competitors into this new area of health insurance, this new kind of market. And so really it just hasn't played out the way people hoped. So yeah, so let me move on and talk really about sort of the state angle here. And start by recognizing that there's wide variability among states, some urban, rural, how dominant, provider and insurance markets are, how, the politics in the states, the regulatory authority that your insurance commissioners have, all those kinds of things, whether states expanded Medicaid and didn't, and all of those things make a big difference for how well the ACA is working in your state right now. So let me first talk a little bit about what states can do right now, and that means, we're talking about open enrollment from now till the middle of December, and there isn't a ton, and it depends again on what the individual circumstances are on the ground in your state. So if you are a state that's running its own marketplace, you don't have to end enrollment when HHS says enrollment is over. You can extend the open enrollment period. And that's one concrete thing that at least those states can do, and some of them I know already have done, to try to make sure to compensate for some of the sabotage of enrollment. Another thing that you can do, if you can do it fast, which is to say like now, is to get more resources out there on the table for, advertising and public education and to support enrollment. That doesn't necessarily mean public appropriation or spending public funds, although that's one way, but can you work with, other stakeholders? Can you enlist all kinds of systems, from school systems to the registry of motor vehicles to whatever. What can you do actively to promote open enrollment in your state right now? And then as public officials, I think that there's a role for people to play to just communicate with your constituents about the importance of signing up, letting people know that it's enrollment, that help is available, notwithstanding anything you might have heard anyplace else. The ACA is still the law of the land. There's still opportunity to get affordable coverage. Most people can get a lot of help to make that coverage affordable, and now it's time to go do that. So, that's really, I think, the focus of immediate action for this enrollment period. Let's look a little bit down the road into like the next legislative session and beyond, and just to think about things that states can do. And this goes back to those problems that I talked about at the outset, and that's partly why I wanted to talk about them there, even though it's a little wonky. So one thing is, not enough plans in the marketplace. What can you do? Well, you can there's like carrots, and there's sticks, and there's stuff that's neither exactly a carrot nor a stick that states can do. There's actually a lot that states can do. So in the carrot category, you can do things that make it more attractive for plans to get into the game. One of those things is to do a state reinsurance pool, and states like Alaska have done that. Minnesota tried to do that, although there was some real problems with the way their negotiation with HHS, I think, was not to their advantage. But there are other states that are looking at that basically pay, the public would assume responsibility for certain high-cost claims. That would make it less risk for the insurance companies to be in the game, and presumably then more would want to. A second would be to do a state individual mandate. That's a carrot, that's a stick really for individuals, but from the health plan's point of view, that's a sweetener, because it's like, well, if the state does that, we'll get more of those young, healthy enrollees, and that will balance out the risk. The only state that's doing that right now is Massachusetts. They had their individual mandate, obviously, before the ACA was passed, but they continue to have one that's state-based. And then third in the carrots category is this idea that you can, you're doing business with these health plans, the state's doing business with these health plans, or, in other ways. So They might be covering state employees, they might be Medicaid managed care plans, and you can give them some credit in bidding on that state business for also playing on the exchange. The flip side of that is that you actually can require them to play on the exchange, and there's different ways to do that. One is to say, well, hey, if you're a Medicaid managed care plan, you have to offer coverage on the exchange. Or if you're a carrier that services our public employees, you have to be there. So New York essentially took the path of basically saying, if you aren't on the marketplace, you're going to lose your Medicaid managed care business as well. Another way to go about it is to say, if you're selling a certain amount of coverage in our state, you can't cherry pick market segments. The ACA said, we're not going to allow you to choose customers on an individual basis. So you can't choose, to cover Mr. Jones who's healthy and leave that, Mrs. Smith who has diabetes. You have to cover them equally. But one thing a lot of insurers have done in response to that is said, like, okay, we're just not going to play it. We're going to take our marbles and go home. But, at the same time, they're still providing insurance in other places. But you don't have to let them do that as a state. You can say, you're in the game, you're in the game. You have to play in this market segment. So another stick approach, it's not actually a requirement on the insurers, but they will see it as threatening, is some kind of public option. States can do that. That didn't do it, but a state could either have people buy into their Medicaid program or some other kind of public plan that the state would construct. And there's a lot of different ways to do that, and you could make that statewide, or you could make that only in certain places where there aren't enough insurers. There's a lot of different ways to structure that. And then sort of along the same lines, but probably less threatening to insurers and to providers who might not like to take Medicaid rates, would be to basically to say that the state would operate kind of like a big self-insured employer, where you would have an administrative contract with an insurer to set up a network and pay claims and that sort of thing. But, the risk would be public. The state would, assume the risk. The insurance company that you contracted with wouldn't be liable for the cost of the healthcare claims. So just to flag, some of these things are completely or predominantly within the state's control. And some things might require a state to get permission from the feds to go forward, or require the state to put some money on the table, or both. And those are obviously heavier lifts in some ways. So just as an example, a state could create a Medicaid buy-in requirement where that made Medicaid managed care plans also have to play on the marketplace. But the question would come about whether those Medicaid managed care plans met all of the same rules that the ACA has for benefit design and reserve requirements and all kinds of things that they might not have to meet to be a Medicaid plan. And if not, you would need to get some kind of federal approval to allow that. And as to whether that federal approval would be forthcoming, kind of anybody's guess at this point. Okay, so let me look at another problem, which is, how do you get more consumers in the marketplace, and how do you get a healthier risk pool? So this goes, again, right back to some of the things I talked about at the beginning. So one thing is that the feds have really cut back on outreach and public education. So a relatively inexpensive, not free, but relatively inexpensive approach would be state can spend more money on outreach. Another thing, we talked about the non-compliant plans and how healthy people tend to be in those plans. That's why the insurers want to keep those plans alive, because they're making money on those healthy people. State doesn't have to allow those plans to continue. So that's another possibility that would move people into the ACA, a healthier group, into the ACA marketplace. A third option would be to supplement premium assistance that the federal government provides with state funds. And again, there's lots of different ways you could structure that. For example, you could focus specifically on additional premium assistance to low and moderate income young people, who that would also have the consequence of bringing average rates down as well. So even though you didn't provide premium assistance to maybe some older folks, they could still see a drop in their premiums. So there's like a lot of different ways to go at that premium assistance. Of course, requires state dollars. And then again, a state individual mandate that, bites a little bit harder than the federal mandate does is another way that you could get more consumers into the pool. I'll just say that anybody who's thinking like, oh, state individual mandate, might want to think about coupling that with state premium assistance or some other kind of way of improving the affordability from the consumer's point of view. The reason that the federal mandate is, most people think, kind of weak, goes right to that problem that I flagged at the beginning, that the feds didn't pony up enough money. So because they didn't have enough money to really truly make healthcare affordable for some people, they basically said, okay, you don't have to buy it, or we're not going to ding you that hard if you don't buy it. Contrast that with Massachusetts, where both the premium assistance is more robust and the mandate is tougher. And it works better, but it's balanced. It's a little tough to go down that state individual mandate route with kind of underwhelming financial assistance that the ACA provides, at least for some people. It's great for some people, but for some it's not enough. Okay, so that goes into this question specifically of premiums and cost sharing being too high. One of the things that you can do to, obviously, if you haven't done it, the very first thing is to argue for expanding the Medicaid program. That not only gives really cheap coverage to a lot of low-income people who don't get any help now because of that design fluke in the ACA, but actually pulling those folks between 100 and 138% of the poverty line who are in the marketplace today, but they tend to be expensive. So you actually pull them out of the marketplace and into Medicaid. That brings rates down. Some of the things that we talked about before about getting more carriers into the marketplace, more carrier competition, that tends to bring rates down. Looking at your regulatory authority, so to what extent are you really able in your state to scrutinize the rates of insurers? And also, and this is a place that people haven't gone very much yet, but I think probably need to think about, is that you have a lot of places, particularly in rural areas, where there's just like no provider competition. So providers can charge a lot, and there's not much that insurers can do about it. And if you're trying to bring rates down, you're going to have to look at some of those provider prices as well, because for the most part, rates reflect both the health of the enrollees and the cost of the benefits. And where there's monopolies, the insurers are very weak in their ability to negotiate on those prices. We already talked about reinsurance, or another option for states, and again, I don't know people's level of technical familiarity with the Affordable Care Act, but is to do something which is a state option, so it's easy, relatively speaking, to get, that essentially would layer a public plan on top of your Medicaid program for those low-income people, and that, for them at least, up to twice the federal poverty line, say, that would give those folks, that's one group that may have hard time affording their coverage or their cost sharing, that give them a better deal. So I think when we think about sort of what's happened federally and the efforts to undermine the ACA, we think about, maybe 4 policies that we call sort of the anti-sabotage policy suite, which are sort of like a set of things that you can do both now, going forward, to sort of make your marketplace work better and protect it against some of the things that the Trump administration has been doing. And the first one of those things is robust outreach. So state needs to step up. Federal government can't be counted on to actually promote enrollment anymore. So, that really tells you if we're going to make this work, our state has to do it. Some states have, a lot of states haven't. So that's one area. Second is to make sure that there are plans everywhere. And I put here on the slide sort of that linkage or public option. Those are more the stick options. You could go the carrot route. But either way, really to make sure that you have plans everywhere, ideally some choice of plans, and doing that will have some good spillover benefits in helping to keep premiums down as well. The third thing is purely regulatory, although I guess that you could actually, certainly could legislate it, which is this idea of, quote, silver loading. And I haven't talked about this before, but the idea here is to make sure that all of the costs of those cost-sharing reductions live solely on certain plans on the marketplace. And the reason for that is that if you keep all those costs on marketplace silver plans, sort of the mid-level plans, and again, apologies if this is like everyone's like, oh, I know all this, but just to level set here. So the idea of keeping those costs all there is that the premium subsidies go up right along with the premium increases in those plans. The premium subsidies are pegged to those premiums specifically. So when those premiums go up, the subsidies go up. And when the subsidies go up, other plans that aren't those silver level plans become more affordable. So that means that people could buy a better plan, a so-called gold plan, which has better, lower cost sharing, and not pay as much for it. Or they could buy a bronze plan, which has more cost sharing, but very likely might be completely free on the premium front. So if you take that step and make sure that the carriers keep the cost in that narrow band of marketplace silver plans, you kind of protect yourselves a lot from the Trump administration's efforts to sabotage the operation of the ACA. And the last thing I want to talk about here is also something I didn't reference before. People may recall that the president issued an executive order to direct his agencies to change some things about how health insurance works. And one of those things was to make these so-called short-term plans more available. And those are plans that don't last a whole year. And the Obama administration strictly limited those plans. And if you let those plans in, then it's right back to those kind of crummy plans that Dave was talking about earlier on. They don't cover very much. They leave you, high and dry if you get sick. But they pull healthy people out and they make your market work much less well. They drive premiums up for everybody else. So, but states can control that. Notwithstanding whatever the feds allow, states can say, nah, we're not going to let those short-term plans be sold, or we're going to really limit them. So we see that suite of policy options. If you're looking for a kind of a fairly robust, comprehensive anti-sabotage policy menu, we think that that gives you like a pretty aggressive menu. So why don't I stop there and see if there are additional questions about any of this from beginning to end, or related things in the ACA repeal and replace arena that you want to talk about.
Sure, and Michael set up this is really going to be in states and local communities' court because they're getting very little support to help keep these markets healthy. Questions that people have and what they can do. We are kicking off the open enrollment phase, and as public leaders and as and staff of public leader offices, there's definitely things we can do to get the word out. Taking the stuff that Michael laid out, what are thoughts, reactions? How do we keep the conversation going? And wait, Bernie, I'll put you on the call. Do you have any questions on? Do you want to jump in there while we get questions being typed in? And
so did I understand you, Michael, to say that a state can refuse to allow the low-quality plans, even the ones that were grandfathered in under ACA?
So there's two categories of plans that were allowed to continue to exist, and it's kind of, super wonky, but there were so-called grandfathered plans, and those, frankly, states can mostly control what, the basic answer is yes. Let me just start there. States really actually have a lot of control over what insurers can sell. Feds basically set a floor. States can always go beyond it, pretty much always. So, federal government says, 80% of your premium dollar has to go to pay benefits, but if a state wants to say, 85% or 90%, they can. There are a few limits to this that have to do with the interaction between subsidies and benefits. So states can't necessarily do a lot of things that would cause federal subsidy payments to go up. But other than that, pretty much states can chase those non-compliant plans out of the market, or they can give them like a 5-year phase, whatever they want to do, and they don't have to let the short-term plans in. Just one caution is, you make those plans go away. That could be good public policy. The people who have those cheap plans don't entirely understand that they're driving around in the equivalent of a car with no seatbelt and no brakes. They're driving around. I have health insurance. It's fine. They don't know that their cheap plan is garbage. And so when you take it away from them, they might not say thank you very much. So that's the only caution there.
We got a question here from Joan. It talks about so all of these companies get out of the market in states all across the country, leaving people with no other, no provider. How do you combat that, and what can states be doing to change that? And I guess I would add an extra question, so why did that happen in some places and not in other places?
So let me answer the second question first. Why did that happen in some places and not in other places? There's a bunch of factors. It was tougher in rural states because they didn't have so many insurers to begin with, or they had a hard time writing contracts with providers that they thought were attractive. It's been tougher in states that didn't expand Medicaid because those enrollees are expensive. So, a lot of states didn't really try very hard to get insurers in, at least at the beginning. And as I said, a lot of states that, maybe for well-intentioned reasons, let these, pre-existing plans continue, that really sort of made the ACA marketplace not such a robust place to be. And then, of course, there was sort of like the federal sabotage efforts as well. So but a lot of places, so a place like California, they're not that affected by the federal sabotage. They've been able to push back, big and motivated. in terms of what states can do, there are really a couple paths. One is, try and induce plans to play, making a better deal for them. That's reinsurance, state individual mandate, anything like that. One is to tell them that they have to play if they're in the state at all in these related markets. Massachusetts had a rule that before the ACA that said if you sold a certain number of policies to individuals or to small groups, you also had to sell to non-group. And that made sure that there were carriers who would sell to non-group, to individuals. So you don't have to just sit there and take it. You can tell them what they have to do. So that's another route. So one route is to kind of try and coax them. Another route is to make them. And the third is a kind of an end run with something that's sort of like either, a public option or kind of the state as a self-insured entity that can just say like, okay, we don't care what you do, we've got this covered. And those are really the three roads I think that you can take to try to deal with the fact that, plans haven't played as much as we thought they would.
Great. I mean, definitely you're outlining a bunch of things that we can be taking leadership at the state level to just accept the reality that we're in right now. These markets only work when, frankly, more people are in them. Not just sick people in them, but healthy people are in them as well. And I think that's incredibly helpful. I've got a question here from Hank that asked a question that when ACA rolled out, Enroll America, a huge amount of attention and effort, navigators trained to get people enrolled. What do we do in the absence of the resources to help support that? And I guess I would add on top of that, what can public leaders, I mean, even the most like a city council member, a state legislator, what can they be doing to help encourage people to enroll and get insurance? If you don't get insurance through your employer, to take advantage of this enrollment period that we're in right now.
So I think that public leaders are well positioned to use the bullhorn, use the microphone that you have to encourage people to sign up. So whatever ways you have, whether you have office hours, you can pen an op-ed in your local paper. You can partner with community organizations that are doing enrollment. Right? You can schedule an open house and say, we're going to have counselors, work with, enrollment assisters and say counselors will be available, representative will be here, or the counselor will be here to deal with local concerns, but sort of feature, health enrollment assistance. So I think that there's, a bunch of ways that you can do that. And then in your governing capacity, I think that's a question of whether you can, like I said, either coax resources out of the private sector or, put some public dollars on the table. And again, it's relatively inexpensive. It's much cheaper than, it's not free, but it's much cheaper than saying like, okay, we're going to provide coverage for, 50,000 people or something like that. It's a lot, getting people signed up. And certainly, a lot of folks, again, local places, counties that have public, hospitals or whatever, it's really in, the community's interest to get people covered and not have to sort of pay uncompensated care for folks that end up without health insurance. So there is a sort of a self-interest for some, government entities. Can I just say one thing here? I want to throw one thing on the table here because I recognize that some of these ideas maybe seem complicated and some of them maybe are like, we could never do that in my state. But the fact is that sometimes it's worth having the fight anyway, just so that it's really clear that it's not, because there is this whole narrative, oh, the ACA is bad and the ACA is failing and all that sort of stuff. And to just make it clear that what's happening is that federal officials, and in some cases state officials, are making choices. Choices doesn't have to be this way. It can be better if you do A, B, and C. So sometimes, even if you can't win it, it's still worth having the fight.
I think that makes a lot of sense. I mean, I've been thinking about this, and I'm a county official. I actually was talking to some public health officials lately, and like, so what is our plan? I mean, it's like, in our county, we're a county of 1.2 million, one of the largest counties in Michigan, and I was a bit horrified on how little preparation. Like, we don't have a plan. I mean, I'm thinking of like voter type things, like voter registration. Like, we have voter registration applications everywhere. Why don't we have the same comparable things, like, structurally built into our public institutions? And it would seem that this is definitely something, and I think, Michael, to your point, is that, I mean, the bully pulpit of elected office gives you an opportunity to talk about this, and the systems of government to be able to say, hey, unless we are deliberately trying to keep people out of the marketplace, which is bad for everybody. It's bad for the hospital systems. It's bad for the healthcare system. That we do a disservice if we don't figure out a way to and get good information to people so that they can make good choices to actually get insurance and have that added security for their families. So it's definitely, I mean, the last few weeks is like it's been running through my head, and I think is there a resource that people can turn to? We talked about writing op-eds, we talked about these other types of things. Is there a resource that people can go to figure out, almost like a checklist, have you done this? And Bernie and I will huddle. We can put a checklist if it doesn't exist, but it seemed to me that there are lots of groups that have been working on healthcare access, healthcare affordability for a long time. Is there a place we can like direct people to be able to answer the questions like, hey, this is what you can do right now, even if it's beyond going to a lot deeper into the nitty-gritty that we did to the last hour, talking about this stuff. In this window of time we have, do the following.
So I'm trying to think about, I mean, we have a lot of outreach and enrollment material, and there are some other folks who are really sort of, taking the, challenge on, and Lori Lotus, who used to work for the Obama administration and helped do enrollment when she was there, has really sort of stepped into a role, trying to sort of combat the lack of, federal support for enrollment, along with some others. So we could certainly make some materials and some contacts available to you guys that you can share with your network. Be happy to do that.
Yeah, I think it'd be helpful for anyone who wants to lean in, especially if they're not schooled up to a point. It talks in depth about it, but this is where you go, this is what you need to do. And maybe I make some sensitive to it. I happen to know, at least in my state, like the people who led the Enroll America efforts and everything like that, and seeing that almost non-existent. And I remember some months ago seeing that only 10% that was available in years past being even available to do this type of stuff and help people through the process. I think would be incredibly helpful, and I know we'd be happy to get it out to our network around the country.
Yeah,
If that's great. If folks have additional questions, I think we're going to be wrapping up here. We've been talking about kind of like what brings us to this point, laid out in some of the reasons why, spelled out a number of things that people can do. I think there really is an opportunity for public leaders to really stake out a bold, proactive effort in the wake, regardless of what's happening at the national level, of things that we can do at the state level to improve access, improve care, and then also be the ambassadors of encouraging people to sign up. And I think can really help move us in the conversation. I guess my last question, unless others jump in here, and this is a kind of I don't know, this is going to lead to a whole nother conversation, but for so long, so many voices that led us to the political conditions that resulted in the creation of the ACA. It seems, and we've been spending a lot of time on defense or sitting and in some cases hoping that the president and his allies are not successful in completely dismantling it. But the voices calling for a renewed effort to expand access to healthcare and make healthcare even better seem to be quieter. And obviously there's some new national attention right now. Michael, from your vantage point, since you've been involved in this movement for a long time, what do you see as our trajectory? Like, what's the next phase of this? Is it weathering this administration, at least under this term so far, to figure out what do we do next? Do we see a building of momentum to really push the needle in the direction of advancing access, increasing access and advancing quality of healthcare for more folks?
Wow. So
that could be a whole nother discussion for another day too. I'm leaving that there because I'm frustrated on some level. At the same time, is that when I interact with folks, the same passion that led to the creation of the ACA, which wasn't perfect, wasn't what everyone wanted, but it made incredible leaps and bounds, and we know that. So, yes, I'm going to give you the final answer for that and the final words.
So what I would say, and it's a good place actually to end, is states are going to have to lead the way here for the next however many, few, hopefully not too many, years. It's really, really hard for me to sort of say, okay, this is what's going to come next, this is what's going to come next. I certainly didn't anticipate the outcome of the election. And then on the other hand, if you had told me a year ago, approximately, just a little bit less than a year ago, after the election, that we'd be sitting here and the ACA would still be the law of the land, I wouldn't have necessarily expected that either. So I think it's true that as long as there are political leaders in Washington who control the various chambers of Congress and the White House that are committed to dismantling the Affordable Care Act and the Medicaid program, we're going to have to play a lot of defense. There's just no way around it. We're going to have to play a lot of defense, and there's just a lot of things that we're not going to be able to stop, for that matter. And that, is hard. But on the other hand, more optimistically, as long as those fundamental structures of the law remain in place, and Medicaid remain in place, there is a lot that states can do to make things better and to begin to plant the seeds for sort of new energy and new way forward to sort of, finish the job that the ACA started. And you've seen this before. I mean, the ACA really built very much not only on Massachusetts, but there were other states that were working hard on various universal coverage or near universal coverage schemes that, helped inform the debate. You've had states going first on children's health insurance before the federal government came in with the CHIP program. you had states going first with pharmacy assistance programs for older adults before the feds came in with, Medicare drug benefit. And I think that our task now is certainly to play defense and to insulate our people as much as we can from the federal attacks, but at the same time to begin to experiment with and begin to push forward an agenda at the state level that can then become the basis for renewed federal progress when that window of opportunity opens, whenever that is.
I think you summed it up well. I think it's a recognition of the reality where we are today, but also, laying the goalposts of where we want to be. And I think this is a great opportunity. I think you laid out, there are things that we need to be doing in the short term to address those realities and protect those who have health care today that didn't have health care before. But I'm also excited, the juices are flowing in my brain, particularly in states that have the ability to raise the bar as it relates to requirements of healthcare dollar, healthcare premiums going to the individual's healthcare, or raising the standard to make certain that if those opposed to expanding access to healthcare are successful and we destroy this thing, how do we make certain that we've got good quality healthcare available to people? So. I think it's a dual strategy, and I think it really claimed the mantle. I just keep coming back to, it wasn't too long ago in which we went into an election season using healthcare to be a center plank of that, and the public rallying with us. I feel like in some cases we've lost that public narrative, though we encounter, polling, research, and a series of other things, people are increasingly more and more supportive of the ACA that's in place, and believe that everyone should have access to quality health care. We've got to kind of reclaim that mantle. I think it's going to be the pathway of positioning future leaders in positions of power to protect, restore what's been destroyed, and really make this country healthier. So with that, well, Michael, I want to say thank you very much for being with us this last little bit. It's incredibly informative. I always learn something when I listen to you, and so I want to, on behalf of the Public Leadership Institute, thank you for your time, for being here, and we look forward to working with you.
My pleasure.
All
Great.
right.
Happy to.
Thank you. And for everyone who's been joining us, be sure to join us, usually about the same place, same time, usually around the afternoon, and Wednesdays live. You can also look to see our recordings on our YouTube channel. If you have any additional information for me or Michael Miller, our presenter, with Community Catalyst today, feel free to email me. I'll be circling back and working with Michael to see if we can get a kind of like a checklist and resources to help you take on a greater role in helping people through the enrollment process, to make certain that everyone who's eligible can take advantage of that, get as many people health care as possible as we weather these difficult national political times. So thank you very much. Thank you, everyone. See you next time.
Bye.